Welcome to our Diabetes Health Matters on diabetes and fertility. My name is Dr Joan St John. I'm the host of Diabetes Health Matters. This webinar series is sponsored by Eli Lilly and Company, although they have no input into the content of the series. We're delighted to introduce Dr Isioma Dianne Okolo, who's a consultant in obstetrics and gynecology. She's also a global health researcher, a maternal health advocate, and an absolute leader in advancing racial equity in healthcare. Dr. Okolo is dedicated to addressing the disparities faced by Black and minority ethnic women, particularly in reproductive healthcare, but more widespread than that. Through her clinical work, her public speaking, her mentorship, she is such a powerful advocate for systemic reform, aiming to create a much more inclusive healthcare system that serves underrepresented populations. Her work has already made her such a respected voice in both healthcare and public policy, and she continues to push for meaningful change. She's going to share some information with us about diabetes and fertility, and as usual, she does it in such a fantastic way. So here we go. Stay active in the chat, ask lots and lots of questions, and we welcome Dr. Isioma. It's an absolute delight to welcome back Dr. Isioma Okolo, friend and colleague, I think I would call you, Isioma. Welcome back. So you're going to share with us your knowledge on diabetes and fertility for Black women. So thanks, Isioma, and over to you.
Thank you so much for having me back. Any excuse to do work with you and Diabetes Africa, I'm always honored to do. So thank you for having me back. And congratulations on all the amazing awards and good stuff you've been doing. So very important subject matter around the issue of fertility, diabetes, and Black women. And, you know, in the wider context of what we know about health for women, health for Black women, health for women who also have chronic medical conditions. We know that, you know, the key message I want to pass is the majority of people will be absolutely fine when it comes to fertility and health outcomes. But compared to a different population who do not have diabetes, we are experiencing higher risks and higher chances of certain outcomes, many of which are preventable. So I think the key thing, especially when we think about Black women's health and thinking not just the UK, but even globally, at the moment, there is quite a negative narrative about it, isn't it? Whether it's focusing on maternal deaths, which are rare in the UK. Birth in general in the UK is quite safe, but these disparities exist, whether it's to do with increased chance of pregnancy loss, delayed diagnosis of endometriosis, fertility challenges, which is relevant to this subject matter, cancer, across the board, very negative narrative. And the key thing is, you know, whilst we want to share these disparities and focus on things that can be done to reduce them, we want to also empower people and for these messages not to cause fear and for people to put their head in the sand. So that's the key thing when I'm talking about these things that I'm highlighting at the very beginning. So what we're going to try and do very quickly is an overview of fertility and reproduction, talk a lot about, you know, how glucose management and insulin resistance can impact all of this, hone in on a couple medical conditions, specifically things like polycystic ovarian syndrome, and thinking about how you can optimize your health pre-pregnancy. Myth busting is something I love to do, and also some final messages as well.
Isioma, we should just say this is about fertility, and we're talking about men and women as well. And also just to acknowledge, I think, that this may be quite a triggering subject for some people, quite a difficult subject for some people. So we want to just, acknowledge that, but share this information so that hopefully we'll all be better informed and empowered. Thank you.
Absolutely. Thank you for highlighting that. So with regards to fertility and reproduction, I will not bore you with an embryology or biology class, but I think it's very important to know some of the key basics. So first of all, it takes two to tango. So as Joan correctly highlighted, we're talking about not just male and female fertility issues as regards to diabetes. So At the core, we're thinking about the important reproductive organs, so the uterus being very key, the vagina and the vulva actually, and the penis. We're thinking about the gonads, which in this case would be the ovaries for women and the testes for men. And thinking about important hormones, so estrogen, key hormone, progesterone, another key hormone, testosterone, and other ones you may have heard, such as luteinizing hormone and so LH and FSH, all key players in fertility and reproduction. The key thing is that there are loads of players involved, whether it's the hormones and the reproductive organs, and with diabetes and sugar control, this can impact the quality of fertility. It can also impact fertility in terms of the implantation and also impact the gonad's quality. So specifically when it comes to the sperm, when there are challenges with blood glucose and insulin resistance, as may impact people with type 1, type 2 diabetes, but also polycystic ovarian syndrome, you have this challenge around increased oxidative stress and reduced quality of eggs, and also a disruption in the hormone levels as well can make ovulation more challenging in women who have diabetes or polycystic ovarian syndrome. Specifically to do with the sperm, poor diabetes control can impact the quality of the sperm by way of this process called DNA fragmentation, but also reduce motility as well. It also can have, I guess, a second pathway impact on the quality of sperm through challenges such as erectile dysfunction. So we also know when it comes to the actual fertilization of the egg and the sperm, and then the actual implantation, when you have poor glucose control, you have lower levels of implantation, and especially in women who have type 1, type 2 diabetes, polycystic ovarian syndrome, you can have challenges around this increased inflammatory reaction within the womb lining, the endometrium, that can then have the secondary effect on implantation. And then even when pregnancy occurs, which for most people it will, you have higher chances, like I alluded to, of miscarriage, particularly first trimester miscarriage or pregnancy loss. And throughout the pregnancy as well, higher chances of earlier birth, also called preterm birth, and also birth defects as well.
So there are multiple ways, Isioma, that you're saying that blood glucose and diabetes, insulin resistance, can affect fertility. So on the part of the male, on the part of the female, on the part of fertilization, then implantation, perhaps things like erectile dysfunction being another pathway to affecting fertility. And then if pregnancy actually occurs, then the outcomes of the pregnancy may be affected as well. So that's why, we felt it was so important to focus on this topic. I mean, there are so many steps along that pathway, and you think, there's so many steps where this could be affected, and so many steps that we have to look at. Thank you, Isioma.
Absolutely. And with those steps, with the potential for them to be affected, there's also that potential for us to improve the outcomes as well with this awareness, which is why this is such an important subject to focus on. So again, we've touched on a couple of these things already. So many of you will have heard of polycystic ovarian syndrome, where you have this hormonal imbalance, commonly manifesting as irregular periods and challenges ovulating and thus falling pregnant. We know specifically alongside with diabetes, if you have superimposed on that, particularly with type 2 diabetes, obesity as itself as an independent risk factor can impact hormone levels and reduce fertility in both men and women. Joan already touched on erectile dysfunction and how this can be a challenge with fertility, but less spoken of is actually female sexual dysfunction, particularly with patients who have type 1 diabetes, but also type 2, this challenge around reduced libido, vaginal dryness, and how all this can compound to just not feeling up to having intercourse and the pain as well associated with it. So if you're trying for a baby and experiencing female sexual dysfunction, it can make it even more challenging because of the stress of what you're physically experiencing. So multiple ways.
And Isioma, I know you're going to do some myth busting later. One of the questions that was very frequently raised with me was when you were telling somebody that they had polycystic ovarian syndrome. I think their immediate thought would go to their fertility. And maybe do you want to touch on that now, or do you want to say a bit more about that now? Because I think that was the key thing, before anything else. That was the key thing that seemed to spring to mind, the people associated with that condition.
Yes, yeah. And I wonder if that's maybe because, I wonder why that is the case. But the thing with polycystic ovarian syndrome is, I guess in my practice, the commonest time I see it is when people are having challenges with their periods, commonly irregular periods or no periods. So I guess maybe it also shows up in that people maybe wanting to try for a baby and then not having a regular period is the first thing that might signal, oh my gosh, this might be a problem. If I'm not getting regular periods, then can I actually fall pregnant? And actually, we'll do an early myth busting. You can fall pregnant even if you're not having periods. So if you do not want to be pregnant, please do not take your lack of periods as a sign that you have natural contraception on board. Just FYI. But I guess so the commonest thing I will see is irregular periods, no periods at all, but also challenges physically with regards to things such as male pattern distribution of hair, either on the face or other parts of the body, acne, quite significant acne, and challenges shifting the weight as well. A key thing we also have to be aware of with polycystic ovarian syndrome is in the long term. So we know it's also associated with increased mental health challenges, anxiety and depression, but in the long term, a slightly higher risk of changes in the womb lining that can predispose you to womb cancer, something called endometrial hyperplasia that can then increase your risk of endometrial cancer. So I agree with you, Joan. PCOS is not just about infertility. There's actually other issues that people need to be aware of, as well as challenges with fertility.
Absolutely.
Mm-hmm. Yeah, but good to raise that there.
Increased risk of developing type 2 diabetes in the future as well with it.
Mm-hmm, mm-hmm. And so with this, when it comes to fertility, the key thing is really planning. If you are somebody who is hoping to be pregnant, once you think pregnancy, you should start planning immediately. Don't wait until, okay, we're going to start trying next month. I think there's, maybe 5 years in advance is probably quite ambitious, but, at least a year of planning in advance, minimum 6 months is very sensible. And the key things to think about really is, what is the current state of my health? How is my blood sugar control? How am I feeling physically and emotionally and psychologically? These are key things. And you also need to be thinking about, I think the medication you're on is very important to be thinking about, to learn more. What is the impact of this medication potentially on pregnancy? And also a very close relationship with your diabetes specialist and your GP as well, with regards to increasing your awareness and knowledge of how some of these medicines may need to be changed, but also what impact that could have on your blood sugar control as well. Key thing. In terms of planning, I always recommend this Tommy's tool, which is an excellent tool to take you through your current state of health and where you want to be. It takes you through a couple key pointers, such as what medication you're on, what's your current weight, what's your current, let's say, lifestyle management in terms of sleep, exercise, diet, key things you need to be thinking about. Once you start thinking about planning for pregnancy, I always recommend for people to start taking folic acid. And if you have type 1 or type 2 diabetes, you should be on a higher dose of folic acid, 5 milligrams. And this you will need prescribed. This you can't get from the chemist over the counter. And the reason for this is this reduces your risk of neural tube defects in your baby. So very, very key thing. Also, no harm in taking folic acid for a year. Your skin and your hair will thank you. Okay, you just have to take a tablet every day, which is a bit of a pain.
Isioma, I've got to just reiterate what you've just said. Because that 5 milligrams, not about the skin and the hair necessarily, but the 5 milligrams folic acid is so important. And you need to be taking this when you're planning, when you're even thinking about your first thoughts about, I might like to become pregnant. folic acid, 5 milligrams, if you're living with type 1 or type 2 diabetes, any other form of diabetes, is really, really important. It has to be prescribed. It's not the one that you can buy over the counter. So that I just want to highlight that again. The other thing I want to highlight, at Diabetes Africa, we have produced a handbook about planning for pregnancy, about pregnancy and diabetes. It is for people who are living with diabetes. It's for people who are thinking about becoming pregnant when they're living with diabetes. It's for policymakers. It's for healthcare professionals. So just to highlight that, that there is more information available as well. And this folic acid is so important. It's the first step. You know, I think it's funny how people book a holiday, okay? They're going to go to back home. And, you know, they book it usually 6 months in advance because it's so expensive. And, you know, they make the preparations. They're going to get their body ready for their holiday. But the same thing has to apply if you're thinking about becoming pregnant. You know, you want to do that, as Isioma said, plan 6 months ahead. Try and get your body, your health ready for the pregnancy. Optimize your health. So thanks, Isioma. Back to you.
And remember as well, it takes two to tango. So, you know, whilst the folic acid supplementation, this higher dose is for the woman, the man should also be thinking about their health in terms of your diet, your exercise, and your weight. I have a slight problem with this tool we use for assessing people's weight, the body mass index, because on some level, I think it is racist in that it has been designed and developed for white male bodies. However, it is a tool we have. A more useful tool I use, especially when speaking with patients that come to see me, is the ratio of your hips to your waist, really. And ideally, you want this ratio to be 1 to 2. Or 2 to 1, depending what way you're going about. So essentially, your waist should be at least half the dimension of your hips, and this is very important. Reason being, if you have what we call central adiposity, so where you're carrying fat, mostly the lower aspect of your abdomen, this is a much higher risk for either poor diabetic control or metabolic control in general, compared to if you have more of what they call, I guess, a gynecoid distribution of fat. So fat mostly in the hips and in the buttocks area. Fat in the lower abdomen is a concern, and that's the fat you really want to shed before you fall pregnant.
Yeah, we're not keen on body mass index.
No.
We know it's used. We know it's utilised a lot. It's in pathways for various things. But we always say it's quite a blunt tool. The waist circumference is also a way to sort of make it more sophisticated and more helpful. So yeah.
Absolutely agree. Yeah. So other than folic acid, what other medication might you be offered when you fall pregnant? So aspirin is a tablet some of you would have heard of. And if you have type 1 diabetes or type 2 diabetes, we do recommend that you start with a higher dose of aspirin, usually from around 12 weeks of pregnancy, and this, or at least well before 16 weeks at the very minimum. And for depending on the health board you're in, some people will recommend you take that throughout the pregnancy, or some people will recommend that you stop it around 34, 36 weeks. And the reason aspirin is particularly helpful is with type 1 and type 2 diabetes, there is a higher chance of blood pressure problems called preeclampsia and also growth restriction in the baby. So there is really good evidence that aspirin can really help with this developing placenta, which is usually the source of the blood pressure problems or the growth restriction problems. It can really help the placenta embed within the uterus in a way that this risk is reduced. I recommend vitamin D supplementation for people pre-pregnancy as well, especially Black women, especially Asian women. I live in Scotland, so I have no sunshine. We all live many of you are in the UK with me, so you share my pain. We do not absorb vitamin D the same way. And again, there's evidence that vitamin D supplementation is particularly beneficial for reducing the risk of preeclampsia. But on taking a big step back, it is really beneficial for boosting our immune system as well. So we spoke a lot about, diet, nutrition, weight, that kind of thing. But the key thing is remembering it's both people involved, the man and the woman involved in taking these steps. Also, a lot of, we already spoke about how sperm quality might be impacted in diabetes as well. We have a lot of evidence now that actually this quality of the sperm contributes significantly towards that placenta, and actually has a significant impact with regards to your risk of things like preeclampsia and pregnancy-induced hypertension. So again, please remember that it's not just you as an individual with diabetes, the woman, your partner as well. If your partner has type 1 or type 2 diabetes, we need to be thinking about these things as well.
I think it's really important to highlight that, because quite often that was quite a difficult message to convey to maybe a man who was living with diabetes but wanting for the couple to become pregnant. I mean, it is about both of you, because you're both contributing to this pregnancy. So it's about optimizing your health. So if we're talking about medications that you might be taking if you're living with diabetes, pre-pregnancy planning, we're coming back to that word, that P word again, planning, preparation, those words are so important, because it's really important that you communicate with your healthcare professionals about your thought about becoming pregnant, so that everybody can be prepared and optimize your health. Essentially, some of the medication that you're taking, which will help your health, optimize your health, improve your health when you're living with type 1 or type 2 diabetes, may not be the best thing for you to take when you become pregnant. So the safest medications for you to stay on when you become pregnant, if you're living with diabetes, are metformin and also insulin. And of course, people will know that they're on other medications when they're living with type 1 or type 2 diabetes. But if you're becoming pregnant, we would suggest as a healthcare professional that you stop those other medications, and either just metformin or metformin with insulin will be the safest medication for you to take. Now, obviously, diabetes isn't just about the blood glucose. It's about all of those other things. We call it, a cardiovascular condition. So it's going to be about things like your blood pressure. It's going to be about things like if you smoke, and it's also going to be about things like your weight. We won't say body mass index. Let's say your weight. And again, you want to optimize all of those things to make your health as best as it can be pre-pregnancy and during the pregnancy, and obviously afterwards as well. So ideally, your blood pressure is going to need more close monitoring. The medication, if you're on blood pressure medication, may need to be changed when you become pregnant. As a healthcare professional, I have to say, just don't smoke. Sorry, that is my advice. It's just not good for your health. So particularly if you're thinking about becoming pregnant, or if you are pregnant, don't smoke. It's just not good for you or for your baby. And trying to get your weight optimized is the best way to go. I think, Isioma, I don't know if you have a preconception clinic within your trust.
Yes, we do actually. And so this is something that ideally people should be being referred to, but you can ask to be referred to that clinic as well. Mm-hmm.
And what do we mean by preconception clinic? Well, remember we said preparation, planning, all of that. If you're thinking about becoming pregnant and you're living with type 1 or type 2 diabetes, that is the time to speak to your healthcare professional and say, look, this is what I'm thinking about. And it may take different forms in different areas. So some places will have a preconception clinic, which will be within the hospital, the local hospital. Some will have them within the community services. Some will be actually in your local GP, primary care service. But go to see and speak with someone, spend some time getting the advice that you require in a preconception setting, giving you the advice that we've been speaking about. So the medications that you would need to stop when you become pregnant, how to optimize your blood pressure or stop smoking, so getting advice with that, how to improve the weight if that is something that you need to work on. It's really important for your future baby's health and for your health as well. And then I think the final thing I would say is just let somebody know as soon as you can if you become pregnant. Because let's face it, it's not always planned, is it, Isioma? I mean, even with the best intention, it's not always planned. But it's really important that you let somebody know as soon as you possibly can. Ideally, after your first period. Don't let it go for the second period before you've informed somebody, whether that's your GP, practice nurse, the local hospital, because you can self-refer, your diabetes team. You have to contact a healthcare professional, let them know that you're pregnant, let them know that you're living with diabetes, so that, again, we can start this preparation and planning just to give you the best outcome possible. Anything you wanted to add, Isioma?
Yes, no, just thank you for highlighting that notifying somebody as soon as possible, because there are specialist teams available that will look after you throughout the course of your pregnancy. And these teams, we are multidisciplinary, so you'll have your midwives, your GPs, your diabetes specialist, who we work with all the way through the pregnancy and after the pregnancy as well. And, as somebody with type 1 or type 2 diabetes, you'll be offered what's called high-risk consultant-led antenatal care, which means you'll just get to see more of your obstetric team. You may be, or quite likely will be, offered additional scans so we can monitor the growth of the baby as well. And we'll also be offered earlier discussions about the timing and mode of birth when you get to that stage as well. Yeah. So loads of support available.
Absolutely.
Absolutely. Ooh, now to my favorite bit. Now, I love myth busting because I think with myths and taboos, one, they are very common in our communities, but two, with me, the reason I'm really interested in myths is because, as opposed to being like, oh my God, that's wild, that doesn't make any sense, it triggers in me, like, I guess, a curiosity, because I think myths and taboos, I don't know what you think about this, Joan, is how we make sense of things, right? I think if we approach it as, oh, actually, this was how somebody or some community was trying to make sense of what they were observing, and they came up with this myth, and myths are just great to, like, chat about and giggle about as well. So here are a couple, and please add in if you come across any others, Joan. These are some myths I've come across. So people with diabetes cannot have children. Absolutely not. And actually, in that context, people with diabetes and polycystic ovarian syndrome cannot have children, and people not having periods cannot have children. So this is absolutely not true. People with diabetes can have children. And majority, if you look at the data, majority of people who have diabetes, who wish to have children, who try, will succeed. It's just that slightly more challenging than the group of people who do not have diabetes. So key thing to bear in mind, so that, again, you're not feeling like this is destined that I cannot have children, if you wish.
I've never come across that one. And I think it's really sad that people would be living with diabetes and having this myth that they might not be able to have children if they so wished. I'm very interested to hear that. I've never heard that one before. PCOS, as I said, the polycystic ovarian syndrome, as I've said, that people would always come to me about fertility with regards to that, but never living with diabetes.
Especially the myth, I think, is especially with people who have type 1 diabetes. I think you see that more commonly. And this idea that actually it's only type 1 diabetes that affects your fertility, type 2 doesn't. And that is, again, absolutely not true. Both forms of diabetes can have a negative impact on your fertility.
And we've explained that, because we've said it's also not just the female, it's also can affect the male. So just to be aware of that. This is a joint journey.
Yeah, absolutely. Remember, it takes two to tango. Okay. And now another myth. I don't know if you've heard about this, that poorly controlled diabetes can cause fibroids or endometriosis. I've heard this more in the context of fibroids, but we know that there is no evidence to support this at all.
Again, not heard that one. That's a new one to me. Yeah.
The reason I raised it here is because we know as separate conditions, fibroids and endometriosis can also impact fertility as well. So in case this is a myth you've heard about and you are somebody living with diabetes who also has fibroids and endometriosis, just so that isn't causing any fear in your individual circle and things like that. Okay.
I can understand where the association with fibroids might come, because fibroids are more common in black women.
Yes.
So whether there's an association, then people thinking that it's not the diabetes, it's not the fibre, or anyway. So
yes,
I can see where the myth is coming from. Yes, I can see that.
Okay, so in terms of the other things we've heard, so it's important as well to remember, and I think we've said this quite a few times, that diabetes in men can impact the sperm quality and the pregnancy outcome. So there's this idea that actually the focus is just on women with diabetes. But if you are a man living with diabetes, this can have an impact on fertility as well for a future pregnancy. So key thing to think about. Again, this other myth around lifestyle changes, so just you're thinking of planning for a baby, and you're like, oh, I can wait till next year when I'm really serious, so I can wait till next month. But absolutely, as soon as you're thinking of having a baby, both the man and the woman, you should be thinking about these lifestyle changes, and they should happen before you fall pregnant. And I guess that just lands on the last key message, which is that fertility is a shared responsibility and journey. So remember, it takes two to tango. So we need to thinking about it from both the male and the female perspective. Have you heard of any other myths you've come across in your circles?
No, I don't think so. Specifically related to diabetes, no. I think that covers it. I think the other thing would be that people feel that they can actually sometimes wait until they get pregnant before they actually institute any lifestyle changes or get really serious with themselves. But I don't want to use the P words again, but the preparation and the planning are prior to. It's not about waiting until that time. So another one that has been highlighted, perhaps, is that big babies are normal.
Oh, I've not heard that. That's interesting.
Right, but I think along with that, I would say that I don't think it was recognised previously that if you had, I'm putting inverted commas, large baby, there may have been a metabolic disturbance going on which led to that large baby. Previously, I don't think that used to be recognised, that this could have been associated with the mother having a high blood glucose level at some points during the pregnancy. That's not the case. That shouldn't be the case now. But I think prior to, that used to be the case. So it's not really a myth. I suppose it's a historical effect, yeah. And another one that's been pointed out to me, remember you used to need to eat for two.
Oh, yes. Oh, I've heard, I think I heard that actually 2 weeks ago.
Well, that used to be widespread before. Yes, that you need to eat for two. You don't need to eat for two.
No.
Baby's going to get fed. You just need to have a healthy diet and that should be fine. So yeah, I think those are it. But I'm sure maybe some will come up in the Q&A.
Yes.
Yeah.
So we really want to hear what myths and taboos people have heard of. Interesting. Yeah. Good stuff. So I guess to round things up then, I know we've said the P word, but really preparation and planning is key, right? As somebody living with diabetes, this is your lived condition. You have the lived expertise. So you should really be approaching fertility planning, pregnancy planning as you're the boss of this. You should be aiming to be as much of an expert as your team. Because your values, your experiences, and your concerns are actually key to the success and also for you to feel as confident and comfortable through your fertility journey. Education and support is so crucial. There's a lot of information out there. Sometimes Dr. Google, you get all sorts of wild things. But again, there's loads of very well-known resources. And actually, Diabetes Africa, if you've not looked at their resources, why haven't you? There is a whole package of resources available, and culturally curated resources, particularly for people living with diabetes in our community. So there is more than enough information out there. And there's also support groups as well. So if maybe online stuff is not your preference, there's in-person support groups available that we can point you to for this journey. And a key thing as well is feeling empowered to advocate for yourself when you're looking for whatever support in person or the resources is a key thing. And remember, it takes two to tango. We're thinking about how fertility impacts both men and women living with diabetes. And you think about it as opportunities to optimize your fertility and pregnancy journey.
Absolutely. Thank you so much, Isioma. I would just reiterate what you said. I think advocating for yourself, if you don't feel able to do that, take somebody with you. Take somebody with you on this journey. Make sure that they're as educated in this journey about your pregnancy as you are. And that will help you. Because sometimes, pregnancy can be challenging and sometimes you don't have the energy or the capacity. So having somebody who's equally informed alongside you is really important as well. Isioma, that's been brilliant. Thank you so much. I know there's going to be lots and lots of questions. So we'll take the questions now. Thank you.
Thank you.